So my name is Chee Kay Cheung. I'm a nephrologist and honorary associate professor based at the University of Leicester, UK. My area of interest is in clinical trials in glomerular disease and especially in IgA nephropathy. Yep, so it's a real pleasure to be here at NKF at Long Beach. I was really pleased to be invited to give a talk here on one of our presentations, which was on a matching adjusted indirect comparison of treatment arms in the PROTECT study compared to standard of care settings in real world and in other clinical trials. And the other poster that I was asked to present was of our SPARTAN study in incident patients with IgA nephropathy, which is a mechanistic study which looks at Sparsentan treatment in newly diagnosed patients with IgA nephropathy. So the first study that I'm going to talk about is of our matching adjusted indirect comparison of the PROTECT treatment arms and of the active control arm that received irbesartan compared to other standard of care settings. The reason why we did this study was, to put it into context, the PROTECT trial, which was a phase 3 randomized controlled trial of Sparsentan versus irbesartan, showed that treatment over 2 years in patients with IgA nephropathy, treatment over 2 years with Sparsentan led to a significant protective effect against kidney function decline and proteinuria, and also reduced kidney outcomes compared to patients treated with the active control irbesartan. This study led to Sparsentan receiving accelerated approval and is now approved for use in IgA nephropathy. The other thing about this trial was that patients on Sparsentan exhibited one of the slowest declines in kidney function compared to other phase 3 clinical trials in IgA nephropathy. However, one of the caveats is that the effects in the trial were slightly blunted because rates and progression in the control arm were also much slower than in other phase 3 trials. And that could be due to a number of reasons, but one of the main reasons is because patients receiving irbesartan were receiving that in a blinded fashion and therefore were being up-titrated and pill count was done and patients were almost 100% adherent to the maximum labeled dose. So in order to put these findings into context, what we wanted to do was compare the findings in the PROTECT study of both patients treated with Sparsentan and also patients on the control arm, compare those findings to other standard of care settings. And the settings that we chose were a real world setting, which is an observational study from the UK RaDaR registry, and also another setting from another clinical trial, which was the phase 3 NefIgArd trial. So the comparisons that we did were of PROTECT findings from the Sparsentan or irbesartan arm versus UK RaDaR study, the observational study, and also comparing those to the control arm from the NefIgArd phase 3 study. The way we did these comparisons was by using a statistical method which is called matched adjusted indirect comparison. And the way this works is that essentially you can weight your findings according to patients who have individual patient level data from the PROTECT study and weight their findings to match the cohorts from the aggregate data from the other studies, the RaDaR study and the NefIgArd study. So after we did our matching, we were able to have a more robust way to make a comparison between these findings. And what we demonstrated through these studies was that treatment in both the Sparsentan and irbesartan arms of the PROTECT study exhibited much slower rates of kidney function decline compared to the real-world setting, which is the RaDaR study, and also, interestingly, against the control arm of the NefIgArd study. So I think these findings really put into context the findings that were shown in the PROTECT study. So the poster that I presented yesterday was of interim findings from our SPARTAN study. Now the SPARTAN study is a study of open-label Sparsentan in patients who have been newly diagnosed with IgA nephropathy. So it's unusual because the study includes patients who have a new diagnosis within 6 months, so 6 months from biopsy to entering into the trial. And the other thing is that the patients had to be naive to treatment with ACE inhibitors or ARB therapy. So these were really new treatments with Sparsentan in this patient group. And what we found from our interim analysis was, and this is limited numbers so far, 7 patients followed up to a maximum 36 weeks. But what we found was by taking this approach, we showed significant reductions in proteinuria, up to 80% from baseline on average, and stable kidney function over that treatment time. The population that we enrolled into the SPARTAN study differs from the phase 3 PROTECT study because they're a younger cohort with more preserved levels of kidney function. In future conferences, we aim to present more findings from this study, and this study is going to look at some of the mechanistic actions of how Sparsentan works. So we're doing repeat kidney biopsies at week 24, we're doing level measurements of measured GFR, we're looking at bioimpedance measurements to look at whether there is any evidence of fluid retention, and our interim analysis so far shows that there's no evidence of fluid retention in patients treated with Sparsentan. And we're also doing MRI scans to look at the kidneys and to look at the heart as well. And we're doing biomarker studies as well, and hoping really to through these studies to look at a more mechanistic action of how Sparsentan is working in our patients with IgA nephropathy.